All right. Dr. Vincent Marchese, how are you, man?
I'm good. Thanks for having me.
Yeah, thanks for being here. Shout out to Sassy because that's how we got you on here by calling you out on that episode. So
Yeah, and I think I connected the two of you guys, so
that's right.
it all comes full circle.
That's right. She just cut the line and and showed up
Yeah.
right here. But dude, we've known each other for I guess coming up on 3 years now, and
Yeah.
it's cool because we've had this parallel journeys. Well, actually, I don't know why I'm going to tell your story. Let me let you tell your story. So for the listeners, so we can introduce you to the listeners, why don't you tell us a little bit about your origin story? What led you to sports medicine and kind of where you are today?
Yeah, I mean, I think I had the classic story of kind of always wanting to be a doctor, 12 years old, watching House and like wanting to do it all. Then, got into medical school, thought I wanted to be an orthopedic surgeon. Quickly, didn't even know what sports medicine was at the time. Quickly realized I didn't want to spend my life in an OR. And yeah, had a really cool lecture with a sports medicine doc in medical school, and it totally changed my life and the direction of my career. Then, as you guys know, you got to make a decision on what pathway you want to kind of go into through that. So I chose family medicine, which I really enjoyed my family medicine residency. And I think we'll talk about it later. I'm starting to do a little bit more of that again. And then ultimately a sports medicine fellowship. And yeah, and now practicing sports medicine kind of hybrid mix, I guess. Part of that is what we'll talk about. Came from a traditional insurance model and now, started my own direct specialty care business, which is, I guess, what brings me here today.
Yeah, I want to get into that a little bit, right? So you came out of fellowship, you went right into private practice, right?
I did. So yeah, I joined a small private practice with two providers that I knew well, one of which I did some training with, who were trying to break the mold themselves. And by that meaning, in this area, it's really dominated by some big ortho groups. We won't name names, but they practice a certain way. It's high volume, and these doctors were trying to kind of break that mold and get back to like some different, more time with patients, kind of more personalized boutique care, but still doing it through the insurance model. So I helped them start a practice. They had an established practice for a year. I helped them start a satellite campus in New Jersey, there in Pennsylvania, and just kind of quickly realized that I hated insurance, for lack of a better term, and I thought it was. And yeah, I'm gonna hold no punches today. Sorry, insurance companies. I just thought it was just not the version of medicine I wanted to practice for the next however 20, 30, 40 years. Decided to leave that practice, took some time to kind of make some life decisions. And then funny enough, truly, guys, you guys had Dr. Una on, like the Docpreneur thing, and heard her podcast with you guys, read the book on the beach on vacation one day, and was like, I'm doing this. Like, I'm just going to start a practice. So you guys are really were the initial inspiration for this practice. So it's cool how that comes back.
Yeah, I love it, man. When you told me that, like I was super excited. I actually was not able to make that, and so Darsh was doing that solo. So we'll give all the credit to him for
Okay.
being a great host
I
there.
forgot that.
Yeah. If I was there, I probably would have ruined it somehow. But you mentioned you hated the insurance model, so let's talk about that. Like what was your breaking point? And I'm curious, was there a specific instance that was kind of the straw that broke the camel's back? Was it just kind of death by a thousand cuts? Why did you do switch aside from the inspiration from Dr. Uno?
Yeah, I never truly had the traditional orthopedic job, but a big ortho group where I was seeing a million patients an hour. I got that experience through, residency and fellowship, obviously. And I knew I didn't want to go into that. And, so the start of going into the private practice I went into to start for the first couple years was already trying to get away from that, right? Trying to get back to spending time with patients, not 7 and 10 minute appointments, but 20, 30, 40 minute appointments, and really trying to practice good medicine. And unfortunately, while we were trying to do that, if you are in the insurance model, there's a reason those practices do it that way, such high volume, is because the financials don't make sense. And that ultimately what I saw or what I felt I was seeing was that, okay, I want to practice this way, but financially it just doesn't work. And so, yeah, ultimately I wanted to get back to, personalized care. I shouldn't even say get back because I've been searching for this since I've been out for 3 or 4 years now. I want to practice this way, and I don't really feel like I need to compromise and practice any other way. So yeah, that's kind of the start of how this practice was built.
It's funny because I think a lot of students they're going into medical school and they have that this sexy mindset of down the road in terms of how you're going to practice medicine. It's altruistic. I don't know many people who are going to medicine because they want to make money. That's
Yeah.
just not the case.
The classic term is we want to help people, right? That's what we do.
And they have this idea of, okay, I'm going to do this preventative care, proactive, particularly in the current generation of students going to medical school,
Yeah.
maybe even our generation. And you don't really have a sense of what it's like, the business of medicine, which I always say dictates the practice of medicine. And Darsh, I think you've talked about this before, where like at attending, you have no idea, or like the students don't know what residents do, and residents don't know fellows, and that kind of stuff at different levels. And then you get into it, and you're like, oh, this is real life. This is how it goes, right? It's a business driving. You've got admin who are directing decisions you're making, like how you are actually seeing patients, how you're delivering care, and how that's compromising care, which ultimately, that's kind of the moral injury that builds up over time and leads to burnout a lot faster than we'd like it to, And so I think that makes it really, really challenging. And yeah, there really isn't a point where you're getting back to it. It's maybe getting back to this dream that you had when getting, and certainly the case with me, and I know Darsh too, and that's why we connected. But a lot of people, listeners, students that have reached out to me, and so you started your direct specialty care. You
Mhm.
mentioned you're kind of doing this hybrid model. I'm curious. I wasn't aware. I thought we were doing more sports performance type stuff. So tell us a little bit about how far along are you, and what are some of the earlier challenges that you've experienced? Actually, let me back up here. I'd like to start off looking at it from the patient lens,
Okay.
because I think Sassy did a great job highlighting the practitioner side, and I do want to come get your take on that. But let's maybe start off from the patient centric view on this, and talk about some of the challenges patients face with traditional insurance models. Whether it's deductibles, super bills, limited access, et cetera, et cetera.
Yeah, I think, and part of what I did was I actually wrote down a list of terms. So I think one of the things I wanted to like debunk or demyth or demysticize is like all these terms because the insurance model, or I should say the medical business model right now, big industry medicine, has really done their best to just make everything as confusing as possible for everyone. When thinking about this podcast, I was like, oh, who needs to know these terms? And it's really like, it's patients, it's providers. I'm sure that you have medical students and residents and fellows who listen to this, and maybe even some attendings that just have no concept about how medicine actually works. So yeah, as I've said, my big gripe has been with the insurance companies. And I truly think that they're ruining medicine or have ruined medicine. And there needs to be some big drastic changes that aren't going to happen overnight. But this is my attempt at making my small little change for that. I think it's important to, if you don't mind me, like go back and let's talk about where all this came from and what medicine looked like. So just kind of brief history and not to bore people, but like
Let's do.
where did insurance come from? What was it? So really like early 1920s, you had mostly you either had hospital-based care or outpatient-based care, which is very similar to today. And nobody had insurance, right? And then, every so often, somebody would get a large hospitalization or major surgery or catastrophic event, and it would ruin them financially, right? And that's not a good deal. So catastrophic care was built out of these scenarios, and actually Blue Cross is one of the first providers, and started out as a non-for-profit entity who was really there as a safety net for patients, right? And it's funny to say that out loud and now think about where that is all at. Then post World War II, this all transitioned into um, more employer-based programs. Then in the 60s, you get Medicare and Medicaid coming in because the elderly and the low income who don't have jobs need insurance. And then the kind of behemoth happens in the 70s and 90s where you get kind of managed care and network-based care, and all hell breaks loose. And all of a sudden, you get insurance companies that went from being the safety net for patients to all of a sudden being gatekeepers and profit mongers in the healthcare industry. So that's kind of the history of it, right? And then so I think let's walk through like what a typical, like if you need healthcare in the United States, what happens, right? So most people, if you're employed, get an insurance policy through their job, which I often now get texts and calls and emails from friends and family and other people about how to decipher these things when they're trying to pick a plan, because that's like step number one is how to pick a plan, and nobody understands what they're reading. And the first thing you're doing is paying a premium, right? So you're paying to be part of this insurance's network. And however much comes out of your paycheck and then comes out of your employer side is the premium, which have gotten crazy, right? I think people don't realize that. They see what comes out of their paycheck, but what they're not really realizing is also what's coming out of the business side as well. But an average premium for a single person may be anywhere from $15,000 to $20,000 a year in cost for both the patient and the business. Add a family to that, it could be $30,000 or $40,000. If you're a small business, which I had a conversation with somebody the other day, it could be $50,000 or $60,000 for the year. So these things get really out of hand, and that's just step one in the process, right? So then a patient calls an appointment or calls an office to get an appointment. They first try and figure out, are they in network, right? Everybody, that's the step number one. Are they in network with my insurance? Which is a question I get all the time. I now get to say no, which is nice. And then what people often miss, and I try and have this conversation with a lot of people, is tiers, right? So yes, okay, step number one, you're in network. Step number two, what is your tier, right? So like, how often would you talk about this? Do you know if a patient comes to see you tomorrow, like, do you know what tier they are with you based on their insurance? The answer is probably no. When you go looking for these things, they're purposely hidden and hard to find. And basically for the patients who are on there, or even I guess for the medical students and such, tier one is kind of most covered. Tier two is, middle coverage. Tier three is small coverage. And that's basically how much out of pocket are you going to pay? So then you get to your appointment, you pay your copay, which could be different for a specialist and a primary care. You have your visit. If you're lucky, maybe it's 7 minutes long and you get to spend a little bit of time with your doctor. Then you think all is well, you either do or don't get the treatment that you thought you were going to get. And then 6 months later, you get a random bill or an explanation of benefits as it will be sent to you. And what you'll forget was, what plan did I pick and what was that deductible and why did I pick the one that was $10,000? And this office visit that I thought was going to be covered by my insurance, that the office now charged $500 or $600 for, with my $10,000 deductible, I'm on the hook for the whole $600. And now I got to meet this deductible for, the rest of the year. And guess what? I didn't think things were going to cost me $600, so I'm not going to the doctors anymore, right? Let's say you do have a good deductible and it's low and it's a couple $100, and that same appointment that's $600, now you're only on the hook for whatever the 300 of it, or you think so, because then there's co-insurance. Wait, we didn't talk about co-insurance yet. So that's the 20% that your insurance does not pick up. So even if you meet your deductible and you're over that limit, then you're still on the hook for 20% up to, wait, what's the next one? Out of pocket maximum. So then now I got to look at my plan again. What plan did I pick? Now I'm at my out of pocket maximum. Maybe it's $20,000 for the year. Okay. So if I have huge surgeries and hospital bills and all that kind of stuff, I could end up paying another $20,000 on top of the $20,000 premium that I've already paid already. So I know that was really long-winded, but I said it purposely just to prove a point of how confusing that is. Let me tell you how an appointment goes at my business. You schedule your appointment, you have your visit. My price is posted online, $150 for a new patient visit. You pay that price at the end of the visit. You never see a bill again. So I just took a 30-step process and broke it down into 3 steps: schedule, visit, pay. And you knew exactly what you were getting into, exactly what you paid for. And I purposely have people pay at the end of my visit. I've never had this happen, but God forbid somebody didn't feel like they got the care they needed, I would not charge them.
Oh, that's awesome.
I do it at the end of the visit because I want them to feel like they got something for their money.
Yeah.
Right? They knew what they were going to pay coming in. Did I provide what I said I was going to provide? And you pay for your visit, right? So I just took this gigantic, complicated system and turned it into a 3-step transparent system. So I know I just threw a lot out there. I'm curious your guys' thoughts, but I've been thinking about that all day long. I'm like, I really want to say all these terms, confusing terms, and put them out there because they are confusing. And again, the whole model is to confuse patients so that they end up picking something they shouldn't pick, and then the insurance company doesn't have to pay, and the whole 9 yards.
Dude, that was amazing. And I think in our 170 plus episodes we've done, I don't think we've never had a 15-minute Instagram reel right there. That I wish Instagram allowed us 15 minutes. I would just post everything you just said into that, because I think me being a brand new attending, half of that stuff I'm still trying to learn, right? And at least I have case managers
Exactly.
and stuff to do it for me. But yeah, I mean, providers have no idea what the back end or
And
the
you
front end of all
you
this
should
insurance stuff looks
know,
like.
right?
Absolutely. I've got my oral boards tomorrow, right? And I'm prepping for it. And there's actually like some insurance questions on there. And I'm like, oh man, I got to start asking ChatGPT here to give me the high yields that I need to know about insurance. But
Sure.
before we go into, your business, I want to stay on this topic, and I'm interested because you gave the whole history of up to where we are now. Where does insurance go from here in your eyes as you look at where medicine is heading, right? There's a lot of
Yeah.
physicians. I think there was an article on Doximity just recently actually talking about how even these older generation doctors want to get out of medicine. There's us, this fresh blood that, as Altamash alluded to, that we have this vision of how we want to practice. And when we see reality for the first 2 years, we're like, oh no, we're not doing this. Let's get out. And which is what you guys
Yeah.
are trying to do, right? So where does insurance go from here? What are the trade-offs that we might see? What are they trying to optimize for? Is it still money? Are they seeing this big picture? Just your thoughts on that.
Yeah, I think no, right? I think they just have too much control. And I'll preface this by saying I know I'm making light of this and joking because sometimes like humor is the only way to stomach some of this stuff. But it's gotten so big and out of hand that there's not an easy answer, and I'm aware of that. Anybody who says they have a quick fix is lying, right? This is a really complicated system. Each one of those pieces I just talked about could be an hours long conversation. But just some simple facts to the business of medicine. Ensure every dollar that is spent in healthcare, every single dollar that a patient spends in healthcare, 51 cents of the dollar goes to insurance companies. That's outrageous. There's no other business that happens in. I have this conversation with small business owners all the time that ask me why I'm doing what I'm doing. And I'm saying, imagine if 51% of all the revenue that you brought in went to another company that managed you and gave you all your rules and gave you headaches all day and all that kind of stuff, right? So to start, where the insurance profits at, insurance, that was a little like subtle thing. The insurance companies are headed, it's all about profit, right? How do we increase margins? How do we get people to pay high premiums? And how do we pay out the least? That's the name of the business, right? It's not the safety net that it was once meant to be. So how I talk about this typically to patients and how I think it makes the most sense to simplify as best as possible is it should be like car insurance, right? I truly think in my vision, the way this would work is that most people have what they used to have in the 20s, which was catastrophic care. Premiums would be much, much lower. The majority of people would never use their insurance. You would use your insurance if you have a huge hospital stay, if you have major surgery. We're talking things that cost $20, $30, $40,000, although we could have another conversation about they actually don't cost that. But bills of that such and everything else you would pay for cash, right? The same way you do with your car. Nobody uses their car insurance to get a car wash. Nobody uses it to get an oil check or, an oil change or to, God forbid there's a, little issue with their car. Nobody goes and runs and uses their car insurance. It's for catastrophic care. So that's to simplify things. I think that's where they need to go back to, which would take a lot of the gatekeeping and bureaucracy and inflated prices and all this stuff, kind of reel that back and make it a transaction between a provider, a medical provider, and the patient, which is ultimately what it should be, right? If you allow me, I always joke with my barber about this, who I'm close with. I said, imagine if somebody came into your barbershop, he owns this barbershop, and said, he has clients the way I have patients. I said, imagine if somebody walked in, like the insurance, they're basically the miles, and said, I'm taking over this business now. You're going to keep the business. Your clients are now going to be my customers. They're going to pay me to come to you. When you do a service, you're going to send me a bill. I'm going to tell you what I'm going to pay you. And then you'll be happy with whatever I give you. And by the way, most of the time I'm going to make it really hard for you to get paid. And all along the way, I'm going to try and put in roadblocks so that it's difficult for you to get your money and that you hopefully eventually give up and then I keep more of the money. Like, no, I said, would you go for that if somebody went for that? And he's like, no, that's insane. I'm like, exactly. That's medicine in a nutshell.
And not only that, you're also going to make it harder for those clients to get some of the services that they're trying to get.
Correct.
Right?
And every so often you're going to keep jacking the prices up because I'm not paying you enough. And then every so often we're just not going to pay it on. And then the patient's going to be, or your client's going to be on the bill for an inflated bill that we're not going to cover.
Yeah. But then you're going to give these amazing discounts. You forgot about that.
Yeah.
Like
well,
600% discount. right?
I know. Yeah. Only if you know about it. Only if you know to ask.
That's right.
Right.
That's right.
These are the conversations I have with people right now.
Yeah, yeah. I think I was recently telling you about the Darsh. Like, yeah, I think I was trying to get a CTA done. My cardiologist thought that it was appropriate. Like, I got rejected, and then I was like, okay, well, what's I think the first institution that I'd called, they were like, oh yeah, listen, it's not covered, but we can give you, I don't know, like the price went from $1,100. They were like, we give you an 88% discount to bring it down to 300. I was like, well, why don't you just charge 300? There's an idea. So it's just because we know when you shop around a little bit like that, that's not really what it costs.
On average, the discount is 90%. That's the self-pay or the rate. Yeah.
Yeah. Yeah, no, man, I want to echo what Darsh said. I think it's really important for us to have covered those terms. I think the fact of the matter is the majority of the people do not understand what they're getting into and a lot of times they don't even get to pick, right? Your employer is the one who's picking the plans and you just have like option A or option B. And like, you're going to pick the lower premiums because that's what's looking like, and people don't understand the differences. And then I'd probably say that's one of the main reasons. And I think this is true. Last I checked, the number one reason for bankruptcy in America is medical debt. For that reason.
Yeah, you're right. It's going to change though. There have been some things put into place where medical debt is not going to be able to basically consume people the way it was before. But yeah.
Yeah. On that note, I think a couple of resources, and I think I got this from Marty McCary talking about. See if I can remember it. I think
I'm halfway through his book too. It's great. Yeah.
Which one are you? Are you the Price We Pay or
Price We Pay? Yeah.
Yeah. I think there's Fair Consumer or like it's just like the Kelly Blue Book for that one. There's another one. So basically, like this one allows you to go look at like price shop regionally, like what a service might cost. So what does an MRI cost in New York City? What does an MRI cost in Philadelphia? And then see like if you are paying a cash pay rate, which I'm sure like many of your patients do because they're paying, whether they're going out of network, is that something that's appropriate? And then you can actually shop around, and maybe you can even bargain when you're trying to ask for that discount.
Yeah, one of the things I wrote down, and this, I think I might have stole this from Marty's book, is, and what my whole model is really, if you boil all this down to, and I guess really to answer your question, Darsh, the question is, the one key term is transparency, right? Out of all of this that's going on, it's lack of transparency on every single aspect, from the patient scheduling to the patient paying. And the quote from the book was, free markets rely on transparency, right? So like medicine is not a free market. It has not been in a long time. And if we're ever going to get back to it, we need transparency. People need to see what they're paying. They need to know what they're getting into before they have services, and they need to see where the money's going and what these insurance companies are making, what the doctors are making, and where their funds are ultimately going.
Yeah. And the reality is people are starving for that transparency.
Yeah.
Right. I think over the last 6 months, we've seen the healthcare insurance industry just under the microscope.
Mhm.
Some unfortunate events have also happened in terms of how certain people have handled it. We've talked about this before with Brian Thompson, what happened in the response on just from the entire world, from the entire social media platform, in terms of like lack of any condolences. And I think, Darsh, you talked about this, is like people in a sense like felt like justice was being served, even though people weren't really celebrating murder. They were just celebrating like getting back
Response,
response, so to speak. And this reminds me, I think I'll have to find the episode at 43cc. I remember them interviewing this anesthesiologist based out of Ohio or somewhere in the Midwest, where he started his own surgical center, and it's 100% cash surgical center. And so, this guy, and he's been doing it since the 90s, late 90s. So he's way ahead of the curve. And what he found was that making things transparent, like he was just undercutting hospitals left and right. And not only that, people from all over the world, people from Canada were coming out to get like a triple bypass and things of that nature, just because they're like, oh yeah, I can go to this place in Ohio and get a triple bypass for, I don't know, $6,000 versus my insurance company with a deductible and everything and all the things that you mentioned, it's going to be like $16,000. It makes no sense. Yeah. So I'll link that because there's a funny story that they share where a urologist like actually ends up going to his own hospital, and he yells at his admin. He's like, this is the second patient I'm going to lose this week to this institution because you guys are killing my patients with prices. And they ended up giving them, bringing the price of some urological procedure that I can't pronounce from $36,000 to $4,000. So it was insane.
Yeah.
But we could do all this. Hey, we love bashing insurance companies, but I think one key point is that if you're not able to, certainly, find somebody who's in direct specialty care, we'll talk more about that. where you have that transparency. But if you are hamstrung for a little while and you don't have the ability, at the very least, putting your head in the sand and expecting that things to go well and somebody else looking out for you, whether it's your employer or somebody else, that's not going to happen. So you have to understand every single, and once you understand, maybe you can learn how to navigate it a little bit better too and advocate for yourself. I think that's really important too.
Yeah, 100%. And that's ultimately, I mean, I feel like part of my mission with the business and like a part of the conversation I have with almost every new patient is kind of teaching them how to navigate the system. And unfortunately, the system's really broken right now. And that's not going to change tomorrow. So how do we as patients, and I kind of put myself in their shoes, how do we play the game back towards the system, right? Competition, I think, really transparency breeds competition. And competition is ultimately what's going to drive down prices and make things more sensible again. Um, and patients have rights, right? They might not realize it. I think the thing that's going to take or it's going to be the hardest thing to do is to kind of break away the concept that everybody thinks they just pay an insurance premium and then like they get free care. And that's just like not the way it works. And they think that before until they actually start to use their healthcare. And most people don't even use the amount of healthcare that their premium costs them for the year, right? If it was in a direct pay model. And I'm gonna point that out. I like using the term direct pay. I think cash is a negative connotation to it. So whenever possible, I do try to say direct pay because that's really what it is, right? It's a direct transaction between the provider and the patient. Um, because the providers out there, like to the point they're direct pay, like I'm probably making less money than you are in a traditional insurance model. It's not a cash grab. It's just it's a resort back to my principle a lot. But yeah, to my point, they don't know what they're paying. And the message I often say to them, or kind of the quick takeaway here, probably for any patient listening, is you have rights. You don't have to tell anybody you have insurance. It's part of HIPAA, right? Your Health Insurance Privacy Protection Act. You don't have to give any of your information to anybody, which includes your insurance. And the first thing you can do when you want medical care is, go on something like Fair Consumer or something like that and see what things should cost. And then call and ask what the cash rate is, or what the self-pay rate is, or what the direct pay rate is, and what the discount is. And then see what that cost. And then go back to your insurance, not to your insurance directly, but look at your plan and see what your deductible is. Try and calculate how much medicine you think you're going to use for the year, right? Like a quick example, this is every day at my practice with MRIs, right? If a patient has a $10,000 deductible and they want an MRI, first of all, we're going to have to fight to get it approved. And that's a whole nother conversation for another day. Could take as much as 6 weeks, whether it's right or wrong to have. Then once it is approved, the imaging center is going to jack up the price to your insurance to try and get every little bit because they've had arguments forever about what kind of discount they have to give the insurance provider. So that MRI might be anywhere from $2,500 to $5,000. And if you call and get the direct pay rate, it will be somewhere in the range of $400 to $500. So if you have a $10,000 deductible and you don't think you're going to use $10,000 worth of healthcare in the year, why would you go pay $5,000 for your MRI when you can call somebody, say you want to pay direct, you don't have insurance, that is your right, and pay $500? I mean, it's simple math, right? That's what breeds competition, is by that being out there and not just willy-nilly going to a place, not knowing what something's going to cost and then getting stuck with a bill 6 months later for $5,000 for something you thought your insurance company was going to cover.
I think, this is one of those things that we didn't have an answer to, right? Like
Yeah.
I know that, I don't know if this has happened to me or where, but the provider, they'll always ask, do you have insurance? If they
Sure.
find out that you have insurance, at that point, they are not allowed to charge you cash.
100%. So yeah, it's a great question. And this is where I was like on the edge of my seat with Dora and Sassy's thing. And I've looked into this a lot because I want to play by the rules. Like I don't want anybody to do anything that could potentially get them in trouble. As a provider, whether it's a healthcare provider, an imaging center, a pharmacy, if I know you have insurance, I cannot, let me back up. If I know you have insurance and I'm in network with your insurance, then I cannot charge you cash, right? That is when somebody says they're in network with their insurance, let's break down what that really means. It means that the insurance company set an agreement to that provider. They signed a contract to a list of rules that they're going to abide by, and also a list of payments that percentages that they're going to get. It's negotiated rates. So that would be going against or breaking your contract, right? If you're an out-of-network provider, it just means that you never signed a contract with the insurance company. That's what I am with all the insurance companies for my practice. I can charge whatever I want theoretically, and I have the ability to take a direct payment from somebody. So that was long-winded, but as the provider, if I know you have insurance and I'm in network, I must use your insurance. As the patient, I'm not bound to tell you that I have insurance, right? Now, if they want to look you, they have ways of looking you up through the system, and they can do that. But most of these places, and you'll see, I've had these conversations, especially with imaging centers, what you don't realize is on their their direct pay rate is actually probably slightly higher than what they get on
Reimbursement wise.
average.
Yeah.
Yeah, because like sometimes they get reimbursed $3,000 for the MRI, and then like sometimes they like bite the bullet and they get $200 for it or whatever. Those aren't correct numbers, but you get the con. And when they're getting that direct pay rate, they don't have to pay anybody to do the billing. They don't have to get it authorized, right? So they're cutting out a lot of costs. So they love that rate. They're happy to take your money to do that MRI the same day. Most places, especially MRI machines, their goal is to just keep the machine running as much as possible. Keep patients coming in. So they're happy to take that rate. So I've had this conversation with them. This is kind of off record stuff, but they're like, yeah, if people call and say they want to pay direct for an MRI and get that done that same day, they are happy to do it. They are not going to go looking for their insurance and have those headaches. And patients are within their right to do it. So to answer your question, sorry, I know that was long-winded, but the patients it's not in the wrong for the patient to not use their insurance and go pay direct. They have that right. It's in the wrong for a provider to knowingly take a patient's direct pay payment if they are in network with that insurance.
That's beautifully said, right? It's unfortunate because as you highlighted, it's almost like for the clinicians or providers, it shackles, right? Yeah, it's a violation of a contract, but it's a way for the insurance company to mark up the prices. And because you're in network and which you didn't agree to that. You're your boss, right? Like I'm an employee, he's an employee, right? Like, so, well, actually, no, you're an independent contractor, sorry. But you still are in network, Darsh. Like if somebody came in on the inpatient setting, actually I've experienced this on the inpatient setting, if you were to see somebody and they were technically, like you were not in network, whatever the balance is, you can't build it. Like balance billing is illegal. Definitely in New Jersey.
That's new though, right?
Yeah.
Marty's book, which was written in 2019, that was not a thing.
Yeah.
Like people were getting balance billed all the time, getting their wages garnished, which is just insane. You know,
I think
this is all new
2021 or 2022 that came
right around there. But this is not new.
Yeah.
Yeah, surprise billing and balance billing is very, very new that was not allowed.
Yeah, the No Surprise Act or something it's called. But that was a good thing, right? Certainly kind of like
100%.
Like the medical debt was getting out of hand. But that's a really good point. You know, I love this thread that we're on in terms of transparency, but also really tactics to empower patients for making informed decisions. That's what we're talking about, right? So you've highlighted a beautiful tactic here. I love that. Anything else that comes to mind in terms of from a patient-centric view, what can patients do while they are caught up in the insurance-based model? Like how can they advocate for themselves, maybe, save a couple of bucks, things of that nature, even if it means shopping around, et cetera?
Yeah, I think like rule number one is just like never pay the bill right away. I have this conversation with people all the time is like, and we have to back up on this too, because we got to talk about why the prices are inflated, right? Because you kind of misspoke there too. It's like we are, as providers, we're inflating the prices, right? It may not be our fault, but we are the one who charges the inflated prices. This is the beauty, and I should step back. The reason I'm even sitting here today having this conversation and down this road is like really the experience I got with the private group that I was with. Like I got to see behind the curtain finally. And my financials or how I did was directly tied to all this stuff. So it was behooved me to learn what the business of medicine was, right? So I credit them a lot for that. But and we would inflate prices, right? That's just what would happen. So what happens is kind of starting base was here, right? You got providers and you got insurance companies. So providers increase the price. Insurance companies, every time they negotiate a lower reimbursement rate. So then the provider's got to increase the price and the insurance companies negotiate a lower reimbursement rate. And it just keeps going, right? Now, all of this is based off of Medicare pricing, which you can go look at. And I wrote some notes down for myself, what things actually cost. Everybody talks about a percentage of Medicare when they negotiate reimbursement rates, and Medicare's pricing is out there. Now, sadly, the past, I think it's 10 years, Medicare has decreased 20% reimbursement over the past 10 years. The newest cut, I think, was supposed to be 3 something. Now it's 2 and change. But anyway, so for the past 10 years, the reimbursement rates are decreasing to the providers. But they're who sets the rates, and then everybody negotiates based off of that. But so that pattern of price up, reimbursement down, price up, reimbursement down, it has led us to where we're at now, where you see very, very inflated bills for things that shouldn't really cost that much. And it's all fine and dandy if the system works, but unfortunately, it often doesn't. Because again, that inflated bill, if you have a high deductible, or God forbid you don't have insurance and you don't know your rights and you don't know that there are discounts, these secret discounts, right? You're going to pay that inflated price. So the office visit that should have been $150 is now $750. And you have no concept that what it really costs is $150 because there's no transparent rates. So that's where, sorry, I know I got off track there, but that's where all that comes from. And that's not changing, right? That every year insurance companies are going to negotiate with providers to try and pay less because that keeps money in their pocket. And providers are going to try and inflate their bills to try and keep the revenue that they have, to try and keep up with the poor reimbursement rates. And it's just this vicious cycle that just doesn't seem to end.
Yeah. So what should people do, right? So not paying the first bill. We certainly don't want it to go to collections, although that's never, like, medical debt doesn't really go to actual collections. That's another thing that they scare you with. At least that's my understanding. Correct me if I'm wrong there, Vince.
Yeah, so I've been looking into this a lot. You're not wrong assuming that the patient, so it used to, and that's part of Marty's book, right? Some of the first chapters are very, very interesting on that. It could go to collections and they could garnish your wages. So that was craziness over an inflated bill that, that was truly highway robbery. But so it can go to collections if you do not make credible efforts to pay your bills. So step one, I would say for a patient is like when you get an explanation of benefits, look at the fair consumer, report and see what things should cost. Make sure that if you have insurance, they actually ran your insurance. A lot of times they get caught without the insurance, which can go both ways. We'll talk about a funny video in a second. And then if it is at that price, or if you are stuck, that's kind of where you're at, I would call them, and you can't afford what that bill is. Let's say it's actually correct. Then you call and you negotiate and you say, hey, what would the uninsured rate be? I'm willing to make payments. So you have to make valiant effort to pay. You can't just let it go. But yeah, assuming that you're willing to make payments and you're willing to negotiate, it will not go to collections. Now, what did just change in 2024 is that it will not, even if it goes to collections, it will not affect your credit. So maybe that's what you're thinking about. So it can go to collections. Right. It can go to collections, but from I think it's January of 2024, it will not affect your credit anymore, which I think is pretty big. The funny video I was talking about. So this is where all this pricing stuff gets really, really interesting. I don't know if you guys saw this Instagram Reel, TikTok video where this guy, he's a dad and his daughter needed an ambulance ride. You're shaking your head, and the bill's like $1,200, and he realizes on the bill that the bill is $600. He realizes on the bill that they don't have his insurance. So he calls the company and he's like, hey, you didn't have my insurance. So they say, okay. And they run his insurance and they go, okay, it's now $1,200. And he's like, wait, what? It was $600. Now you have my insurance and now it's $1,200. And they're like, yeah, that's the self-pay discount rate. And he's, wait, should I get rid of my insurance? And he's like, well, we can't do that. We now know that you have insurance. We have to charge you that rate. So it's like you're paying money to a company who's supposed to protect and serve you, basically, and they're negotiating rates higher than what the self-pay direct pay rate would be. It's like, just put that in perspective for a second. You're literally paying a company so that you can pay higher prices. Yeah. That's like having an Amazon account or something, and you pay more than everybody else who doesn't have the Amazon account. Just doesn't make sense.
Right. No, I'm pretty sure I reshared that. And I think it was funny because this is an actual call. I mean, the guy is like, he's asking the other person on the line. He was like, so should I cancel my insurance? And he's like, sir, we can't advise you to do that. And he keeps asking, he was like, but you're telling me it would be better if I didn't have health insurance. He's like, we can't advise you. Yeah. This is too funny, man.
Yeah. And for certain patients, I would say, I don't say this lightly, but it's probably what I'm getting ready to do myself soon. Where we've gotten stuck and which really stinks is that federally, there's no mandate on insurance. So that used to be a thing. People talk about the Obamacare Act and all that kind of stuff. Federally, there's no longer a law that people need to have insurance. Your federal tax will not penalize you. At the end of the year when you do your taxes, you don't have to have insurance federally. state by state, and New Jersey is one of those states that I'm in, you do have to have insurance. And basically, if you do not have insurance, when you go to file your taxes at the end of the year, they're going to ask you, did you have insurance for 12 months? And if you didn't, or if you didn't have insurance for a portion of those months, they're going to charge you a penalty on your taxes that is equivalent to the lowest rate that you could get through their state insurance program, which roughly now is around $350 a month. They call it like blanking on the name, but it's basically like it's you participating in the program, which you didn't sign up to participate for. I guess you did by moving to Jersey, but so for certain people, and if you're in a state that doesn't require insurance and you have enough money saved, you can be self-insured, right? Like ultimately, like if you're a small business owner and you have a decent savings, why would you pay $30,000 premium when you could just like save $30,000 a year, invest $30,000 a year, and pay someone like me to manage your care for, we'll get to it, but my primary care service is $150 a month. Like, and you can see me as much as you want and save your money. And then God forbid something happens, you negotiate self-pay rates and you're going to pay a much lower cost. And these are the prices that people don't know, right? Quick ones like having a baby, right? So, if you have a baby, you have insurance, they're probably going to be charged somewhere between $60,000 and $80,000 for that whole stay. I just negotiated the rate the other day out of curiosity. If I go have a baby at Virtual Hospital in Jersey, it's $6,000. Why wouldn't I just, if I'm going to be a self-employed paying $30,000 premium and the only healthcare I'm going to use for the year is having a baby, why wouldn't I just pay $6,000 and I'll save the other $24,000? So I know that's not for everybody, and I know I'm getting into a little bit of a niche here, but there's a world where like if you have a reasonable rainy day fund that like you really don't need insurance.
Yeah, the challenge with that is that what is it that they say most people don't have a rainy day fund for?
I get it. Yeah,
I don't know.
the average can't pay their bill
Yeah.
for the month if they didn't.
Exactly.
Their
They're living
paycheck to paycheck, 100%.
But it's a good point. The challenge I think becomes like, God forbid you get cancer or something like that. But I guess my question would be,
so then emergency insurance, right?
well, that's what I was going to ask you. You mentioned you're looking to do this. Or are you looking to get catastrophic insurance for like big, crazy, bad things, God forbid, never happens?
Yeah. I mean, what I would want to do ultimately, I'm in New Jersey, so like basically what I'm end up handcuffed to do is either pay that state minimum and just have a really, really high deductible plan, knowing that like I'm never even going to touch it, and I'm just going to negotiate with providers for direct pay rates. That the plan is only there, one, because I don't want to pay the tax penalty at the end of the year, and two, God forbid I got cancer or I had a major surgery or something, then I would end up paying my $10,000 deductible, but then the rest of my care, or whatever my out-of-pocket maximum was, and then the rest of my care would be covered. But yeah, otherwise, if I didn't have to do that, I would probably try and self-insure myself, or I would get a catastrophic only plan, knowing that I'm not going to use it only, God forbid, something really, really bad happens, and just try and limit that premium as much as possible.
Yeah. Now that I'm thinking about this, actually not a terrible strategy, although I want to caveat, this is not financial advice for anybody, but what you could
not
do,
financial advice.
not medical advice, no types of advice. But what I'm thinking is, what we could do, somebody could do in that, because those high deductible plans often come with HSA, and HSA is the triple tax advantage, right? It's the only way you can get out of paying taxes, and you could start contributing to an HSA fund on the side, and you're putting money aside. But that's a big thing, like you're talking about. Like you got to be putting money aside, and now that's actually growing tax free as well. And so if you don't use it at the end of the year, you do something with it. I'm
glad you brought it up, because I have you explained that on this podcast before? Because I don't think people realize that. And I have this conversation all the time.
Why don't you go ahead and do it again, just in case for anybody catching up?
Yeah, Darsh, you need to know this too. This is you start doing this. So this is what rich people are doing too. Not it's everybody.
Yeah, that's not us. That's none of us are rich here.
None of us are rich. Let's make that very, very clear, right? We went into medicine. If we should have went into finance or insurance, probably. I'd be a great insurance CEO maybe, but I don't think I think I have too much of a heart. But yeah, so let's talk about HSA real quick. So wonderful, wonderful program, and it's really, I argue you should really never use it for healthcare. There are some ways around, and I can tell you how patients are doing it now in my office with insurance and with HSA. But basically, I think the limit this year for solo is like $4,000 roughly. Don't quote me on these numbers. And then family is like somewhere around 6 or something like that. But you can take this money out of your paycheck pre-tax, right? It goes into an investment fund. or an investment account, Fidelity has them, Vanguard, all these places. That money came out pre-taxed. It grows in value in the investment funds. You can invest it whatever you'd like. You can buy all the Trump coin or whatever you want. And that grows tax-free. And if you don't take it out until you're 65, or you use it for a medical expense, that is tax-free as well. So the majority of people, like if you don't need it, do not use your HSA to buy whatever, your glasses and your Band-Aids. Different from FSA, which we could talk about, but HSA, yeah, you should purely use that as an investment fund. And then that's kind of a self-insurance fund. If you could do that for long enough, then yeah, God forbid something really, really bad happened to you, you could pay, your medical debt with that. But the majority of people, I shouldn't even really say the majority, but if you're financially sound and you don't need to spend that money every year on healthcare, you should absolutely save it. The way I get around it, and this is totally legal, this is, above board, you are allowed to reimburse yourself. So like you can pay, like a patient in my office can come pay direct pay, right? They can, or pay with their HSA card. They can then submit the bill to their insurance for out-of-network reimbursement. If they have, those benefits or, they met their deductible, they can get reimbursed and then put the money back in the HSA. Or really theoretically put the money anywhere they want, and it's still tax-free money. It's kind of the way the loophole works. But you can kind of double dip on the system there. You can use those funds, but then also get reimbursed by your insurance.
Wait, let me just understand this correctly.
Yeah, it's a little bit of a mind bend for a second. So you're taking money out of your
HSA.
Well, you're taking money out of your pay, right?
Okay.
Pre-tax. So you haven't paid any tax on the money.
Right. That's in the HSA account now.
Yep, correct. Which is theoretically being invested in, hopefully, market's down right now, but hopefully going up. You can use that money to come pay for a doctor like me, $150 for my visit. If your insurance has out-of-network benefits, you then submit to them. They will reimburse you probably 80% or whatever it is. And then you have that money back.
Your check. Yeah.
But it's still you still never paid any tax on it.
That's interesting.
Yeah, correct.
Yeah. So, but they can't use their card in that case, right? Or can they still use the card and still get reimbursed?
Yeah, they can.
Oh my God.
Yeah.
This is fascinating.
Now I would argue, don't do it. Like, just keep the money in the HSA, let it grow. Like that's what I plan on doing.
Yeah.
But you can theoretically have people double dipping that way all the time.
Interesting. We're probably taking this for granted. So just so people know, HSA, health savings account. FSA, flexible savings account. So you mentioned self-only coverage limit for 2025, $4,300, family $8,550. Just look this up right here.
Yeah, even higher, yeah.
If you are 55 or older, you can do an additional $1,000. It's like a catch-up rate, they call it, on top of those deadlines. So maybe just because we mentioned it, FSA, can you briefly touch on that?
Yeah, it's a use it or lose it account, right? So a lot of times this money will either come for you, it still comes out of your paycheck tax-free. Oftentimes your employer is giving it to you as a benefit. That's how I see most of the time. And if you don't use it by the end of the year, you lose it. So I think they're kind of crappy accounts. I wouldn't use them.
Maybe for certain people, $500 rolls over or something like that. 500 or 500.
Sure. Some people lose it though. Yeah. Some people don't have any rollover. Yeah. Every account's different, right? Whoever does the account. But anyways, that's my understanding of it. I've never had one. I wouldn't use it. But unless, if you work for an employer and they give you the money, then yes, use it. But I wouldn't be putting any of my money into it.
Cool. Darsh, I see you nodding your head and you're excited. Any questions that we should talk about that you think maybe somebody... Yeah, go ahead.
No, I've been quiet because I've been learning, man. This has been great. So
you gonna learn today.
Soaking it all in. Exactly. I've just been soaking it all in, man. This is good stuff. I don't have anything else in regards to insurance. I didn't know if you wanted to hop over to the DSC side of things and kind of talk about more sports medicine, get a little nerdy, but
yeah, hopefully we haven't lost people on this.
Sorry,
certainly. This reminds me of a conversation we had way back in the archives with Peter Valenzuela. People to go check that one out as well. We touched on some of the similar threads that we're talking about. I think today was maybe more individual side, and that was more macroscopic business policy related stuff. But if people have more questions, they can reach out to us, and maybe we'll do a deeper dive and maybe more systematic in terms of how we approach it step by step. Although I think you did a phenomenal job. But let's shift gears, right? So let's switch over to the practitioner side and look at it from the practitioner lens. You've obviously alluded to the fact that in terms of stress, it's far less stress. This 30-step process. And earlier, your example that you were giving with an organization that's giving MRIs and whatnot, even if you're making 10% less by getting the patient to pay direct pay, that headache, like you alluded to, of not getting paid for 60, 90, 120 days and
If at
going
all.
back and forth, if at all, going
Yeah.
back and forth, correcting little codes, et cetera, like that's worth the 10%. You know what I mean? The extra $30 on a $300 MRI, whatever it's going to be. But what other benefits have you noticed since switching over? And again, you were in a private practice model, so you weren't even salary based. But what are some of those things that people can really look forward to if this is something that you want to embark on as a DSC or direct payer doc?
Yeah, I would say, and to your, I think Josh got asked this question earlier, like, where's this going? I would love to see more docs go this way. I think part of the reason they're not is like you gotta then learn how to become a business person, right? So like I always say like medicine's the easy part. Like, like we train for 10, 12, whatever many years to become really good doctors, and we're really good at what we do. But like nobody taught us how to balance a checkbook and how to get paid and how to run a business or any of these types of things. So that's the big learning curve I'm having now. I find it fun. I'm a type of person, I kind of always maintain the attitude of a student. So I enjoy the learning process of all this. But that's the challenge, I would say. Sorry, I know you didn't like leave with that. You were asking what are the benefits, but I can't talk about the benefits without first talking about that challenge. The benefits of that challenge come with autonomy, right? Like I don't answer to anybody. And I kind of joke with you occasionally about this, Raja, like, yeah, just like the red tape is gone. I just don't care about it and I don't have to think about it. And like when I write my note, I don't like play wordsmith to see if something will get covered. Like I just don't care. Like from my standpoint, and I know it sounds like altruistic, but like really, I just want to provide good care. Like when I leave my office at the end of the day, I sleep really well at night because I know that like I gave my best. Like everybody that walked through my door, a new patient in my practice gets anywhere from 45 to an hour of my time. They got my undivided attention, and I think I provide a really good service. And it's a different model, it comes with different headaches, but at the end of the day, you feel really good about it. I get control over my schedule, which is nice, right? A buddy of mine texted me that he really wants to play golf next week at his place. And I'm like, yeah, great. I can move my schedule around and do that. So, and I don't have to answer. I don't have to talk to my boss. I don't have to talk to the healthcare organization. I don't have to talk to anybody. I get to make the decisions about where I see this practice going. So maybe that's a good transition to like what I'm doing. So I started this as a sports medicine practice because that's kind of what I always wanted to do. But I am family medicine trained, and I always really liked family medicine. I liked the ideals of family medicine. I didn't like the way it was being practiced. I hated just throwing medicines at diabetes and hypertension and depression and all these types of things, and got a little bit into like lifestyle medicine when I was in residency. And for years, part of this thing is creating really good relationships with your patients. So people have always kind of asked like, hey, would you be my doctor? And what they mean by that is like, will you be my primary care doctor? And for years, I've kind of always said no. And then I said, what, actually, I think I would like that. I think I would like to take this kind of, whole person view of health and really, guide people along these journeys of getting better or staying healthy. So I've added like more concierge or a membership based primary care service. And then the last little piece, I look at this at three pieces. I have my traditional sports medicine. I have a primary care service that's membership based. And then I have a recovery and a performance center that kind of ties all this together with some different things like VO2 max testing, lactate threshold testing, RMR. We do a little IV hydration, talking about doing some hormone replacement therapy and peptides and all the things that everybody keeps asking me about. So that's the beauty of it, like the cool thing about my practice is like literally most of this stuff, like VO2 max testing, like I just had enough people ask me about it and I was like, yeah, sure, let's do it. So if things are within reason and they're evidence informed, then and I think patients are going to benefit from them, I'll just make the decision to add it and I don't have to talk to anybody. How long did it take you to get PRP approved?
Yeah, don't ask, man.
Yeah, it took me 30 seconds. Like,
Oh, I want it. Okay, here it
it
is.
took me calling the rep, right?
Yeah.
So yeah, so I say that jokingly. I don't mean to come off that way, but and again, this style of practice has its other downsides, at least in the get go. But the cool thing is not answering to anybody
Yeah.
and ultimately getting to practice medicine the way I want to practice it.
That's awesome, man. Can you take us through a little bit about how you structured those three buckets? And the reason I ask is, do you ever fall into a trap? Maybe it's not a trap, but maybe giving too much advice to the point where, hey, they should be paying for the recovery subscription, actually giving them that same advice, even though they're a patient of mine or they're in the sports med category. You know what I mean?
It- yeah. I take a really like, I don't know how I characterize this, but I just feel like my kind of like guiding morals are just like, if I provide really good care, people will use me. Right. So I don't get stingy over thing. I give people discounts a lot. If I didn't think somebody could really pay and they need my services, I give it away for free. Like, like it's, I'm able to kind of be that way because of this autonomy, but ultimately, like, it leads people to coming back. I had a conversation recently. I'm starting to get some like business mentorship. And one of the things they talk about is like lifetime value of a patient, right? A new patient walks in your door. The kind of underlying things are like, how much did you pay to get that patient? What did you spend on advertising? All that kind of stuff. A lot of my business is word of mouth. And then like, how long is that patient going to stay with you? And what's their lifetime value? And even in 6 months, so I've been open since September. Well, really full month in October. Like sometimes I have a 6 month value on some patients of multiple $1,000s because they just keep coming back. So I don't ever get really worked up about, am I giving something away for free? I just know that like if I'm practicing good medicine and providing good care, they're gonna come back, they're gonna tell their patients. And ultimately it's like self-sustaining that way. And yeah, I don't know if that answers your question, but yeah, that's kind of the way it's been.
Yeah. And that's
Yeah,
not even
no.
including the referrals, right? So if that patient's getting good value, good care from you, and they're going to tell their mom and then somebody else and, be like their family member because they want their loved ones to get the same quality care.
Correct. The biggest, I think some of it to tie us together too, to kind of say like, because it's interesting, what the provider wants and what the patient wants are really the same thing, which is why I started this practice, right? So the patient wants access to you, right? So for me, that means, my office phone number comes directly to me. I often, this may be a bad habit, but I often, answer people at all hours of the night. It can schedule online, right? The beauty of not having insurance is like you go on my website right now, you will see my availability. You can just pick an appointment. There's no hassle of you giving me information or whatever, other than, I don't even ask for payment information. Um, and that's your slot. And I hope that you show up. We have, had some cancellation issues, but I hope that you show up so you have access to me, right? So the patients want access. When they get there, they want time, right? So I spend, like I said, 45 minutes to an hour with any new patient, half hour for follow-ups. I never see more than 2 patients in an hour. How amazing does that sound as a provider? Not to rush from room to room. I only have one room here because I only need one room. I only have 2 chairs in my waiting room because nobody waits, right? So they want access, they want time with you, and they want good care, which comes with that. And I guess the last piece really that I should say is they want transparency in pricing, right? And affordable care. And I think while it comes off initially as like, oh, this doc is cash or direct pay, it's going to be more expensive. What I often have a conversation with people about is like, I'm way cheaper than if you use your insurance, right? If you go to the big box orthopedic, who's going to inflate your bill, you have a $5,000 deductible. That initial visit is going to be $500 to $600. You're going to be on the hook for all of it because you haven't met your deductible yet. You don't even know that you're on the hook for all of it. You're going to get a bill 6 months later. It's way cheaper to come see me at $150. So those three things are the same things the provider wants, right? They want to spend time with their patients. They want transparent pricing on what they're going to get paid for their service. And ultimately that leads to less burnout and, better work-life balance and I have less notes, right? A full day for me is 12 patients, 14 patients, so these things just align very well. So that's why part of the reason I was so excited and felt like the business was going to thrive, and it has been so far, is that like what I want and what the patient wants are the same exact thing. So it's kind of like if you build it, they will come. And like that's what I'm seeing so far. And nobody seems to be blinking an eye at the direct pay. I'm sure I'm losing some patients that don't quite get it yet with the insurance, not taking insurance. And they might view me in a certain way. But once they walk through my doors and they have the experience, they're patients for life and they tell their friends and the circle continues, and I get to provide really good care to some really good people and try and break away from the bad medicine mold, right? I just don't ever want to be a part of that.
Yeah. I do want to say, as excited as we get about this, I think it is worth mentioning that it's not for everybody. Like you mentioned, like if you're not interested in learning about the business aspect of it, then you're going to have a very difficult time.
Yeah.
If you're somebody who just wants to clock in and clock out, which recently it's not for me, but I've come to learn, I think I got this from Sahal Bloom talking about this, that if your job, we always talk about this sexy idea that your job has to bring you joy and satisfaction and contentment, but maybe that's not true. Maybe your job is a way for you to get contentment elsewhere. And I think, Darsh, jump in here if this was your thought process as you was going to inpatient rehab. I kind of felt like you were thinking about this. You were like, hey, I'm going to do this and I'm going to provide a good amount of value, and that's going to give me freedom to do X, Y, and Z and all the other things I love outside. And there's nothing wrong with that, right? Maybe you're not the
100%.
person who's going to be going through direct pay. And like you talked about, like there are times when you're working for free a lot
Yeah.
and
Yeah.
you're not making as much money. I am curious why your rates are so low, but you're not making as much money as you might be in a traditional insurance-based model. So that's
I would,
important to understand for people too.
I would argue while I can increase my rates, and maybe in the future I do as demand increase, I don't think they need to be. And I think the math, I'm not a mathematician, but the math seems to be working out. This kind of gets back to, and I don't want to get political here, but those those first principle models, right? That CEO talks about. You strip everything away from medicine and like what you really need, and maybe this is like the heart of the issue we're talking about here, right? I thought about this a lot as I started in the practice. Like, how do I get started, right? It's a big, overwhelming task of like, wait, all of a sudden now I'm just gonna like have a medical practice. Like what? Really, what you need is you need an office space, and you need a provider, a chair, a table, and in our business, some injectable materials and an ultrasound, and like that's it. I don't need billers. I don't need insurers. When I started this, I had no help. I ran the business myself. I scheduled patients. Well, I let technology do that for me for the most part. I take the payments every once in a while if my assistant isn't here. You just strip everything away to the bare necessities, and you can provide really, really good medicine without all the nonsense. So one of the things that I've really been thinking about, to your point, is not everybody wants to be the business owner, right? And I get that. But I will say that every doc wants to practice medicine the way I'm practicing. I don't know any doctor who says, yeah, no, I really want to see 50 patients a day, and I want to provide not my best level of care because I can barely even get it. Do I even know the patient's name that's in front of me? And yes, I want to write 40 to 50 charts at the end, and I want to do 10 MRI prior authorizations because they denied it all. Like, no, nobody wants to do any of that. So the thing I've been thinking about a lot is like, how do I scale this, right? And that's ultimately what's going to happen. I'm young. As a business, I'm young, and this is going to hopefully grow. But then my next question is like, how do I make this a vehicle for other providers to practice medicine the way they want to, make a reasonable salary, but not have to deal with all the nonsense that traditional insurance-based medicine provides?
So what you come up with? How do you do that?
I think first proving that it works, right? And proving that care can be provided this way for like a provable rate. Now I get it. Some people look at like $150 as a big expense, and I understand that. I would argue like look at what you're spending on insurance and what you're not using, all that money that's kind of getting wasted there. Then I would argue like look at some of the other things that you're spending money on. My classic one, I don't know why I keep going back to hair, but like what women pay for their hair, like $200, $300, right? I think I'm worth a hair appointment. You know what I mean? Like, and I know, but it sounds weird to say, but like we have value, right? I think that people live in this like idealistic world where we're just supposed to like go through all this medicine, or excuse me, go through all this education for free, and I have a mountain of debt, student debt, and then I'm just like supposed to practice medicine under somebody else's thumb and like not make any money like that. Nobody's going to choose to do that, and then you're not going to have bright and intelligent people going into medicine, right? So things need to change. But yeah, we have value, and I think that value is higher than people think. But I also think that the price of to put on medicine or to do medicine is just much lower than what people think it is. So I think, to answer your question, I think I proved that it works. And then I try and be a good businessman, and I try and slowly expand this so that I have more office space, and that more patients know about this. And you really need buy-in. Ultimately, I need things to change probably from an insurance model. And once, if it ever happens and things kind of get broken down and we start to get like true transparency in medicine, in competition, then I'll be in the driver's seat and I'm hopefully ahead of the game is my hope that 10, 20 years down the line that this is just like ready to go. This is what the model will look like for everybody. And I hope so for physicians and other providers, because this is a really fun way and cool way to practice medicine. And I think patients think so too.
Agree, man. I love how you brought up first principles. I think that's such a key to anyone getting started on something new, right? I mean, it's like the Elon Musk of SpaceX. He just broke it down
Yeah.
into first
I didn't want
principles.
to, I didn't want to because I don't like to
That's all right. I'll say
say,
it. I'm a huge fan because I read his book, and I think there's pros and cons to everyone, but you gotta love his acumen in terms of how to build things.
yeah.
Um,
Yeah, but
but
probably the best business mind of our generation for sure.
absolutely, yeah. But it's funny because a couple months ago, a medical student was interested in he started a podcast, and he's like, how do you guys do this? How do you record?" And what you answered is exactly kind of what I said. You have a microphone, you have a recording platform, and a distribution, and then you need a voice and the smallest vision, and then from there you can scale it up, just like you're talking about.
Yeah.
So I really like that idea of that. When we talk about scaling, when we talk about efficiency, when you start thinking about implementation, are you using any specific technology, AI, electronic medical record to really just help you get through the day, so that you're not ending up doing notes at the very end, or a better way of
Yeah.
communicating with your patients, anything like that?
Yeah, I'm definitely and it's funny, I wanted to the kind of, the whole AI scribe thing has obviously been huge and I think is really good. I think it's going to be commonplace, in the next 10 years. But I remember having this conversation even a couple years ago with the private practice I worked for, which I was an employee, not the owner. So I didn't make the decisions. And I was like, hey, this is the future. We all hate notes. Let's jump on this. And I just like got slapped down. And now I get to be like, no, yeah, I'm making that decision. So, I'm currently with an EMR that doesn't use it, but I'm in the process of switching to an EMR that does. And yeah, in every way possible, I feel like you learn as you go. But you take on these tasks and you realize like, okay, I don't want to do certain tasks. And then you figure out how you can utilize technology to make those easier. And I think the first one is AI scribe. So I'm gonna switch to an EMR system. I guess free ad here, hint, has one built in, and we'll also do a lot of management from like a membership standpoint and things like that. But there's a lot of them out there. That's probably the biggest one. And especially, I mean, the beauty of this is there's less administrative stuff. There's more like business side stuff as a business owner, but let's just say like as a provider, there's way less administrative stuff not dealing with insurances because there's just so much less red tape and that kind of thing. So yeah, so there's probably like different things for me as like running a business than like if I brought somebody else on who was just going to practice medicine, like having an AI scribe and seeing like 12 patients a day, like they would just be like living the dream.
Yeah, it's gonna be fascinating to see, next 2, 5, 10 years, how efficient we can be as providers, just from notes, communication, diagnoses, all these different things. I mean, Altamash and I talk about ChatGPT every day, probably more than the podcast, and the different prompts we use.
Yeah.
Um,
We talked about it
so
before
it's
this,
it's
but I used it to build the business. Every aspect of this
yeah,
business has some
100%.
thumbprint of AI on it, and I wouldn't be here without it. I have to say real quick though, back to your point, the way I view things is I always that adage of like, how do you eat an elephant, right? This is how I got through medical school. This is how I got through residency, right? It's just one bite at a time. So I just like I take the process, whatever it is, I make the list, and I just check off number one, and then I check off number two. I just keep going, knowing that like I'm gonna get it wrong most of the time, but then you new edition and new version, and you slowly get better and better and better. And I'm excited to see like what the product is right now, meaning what the patients get. I'm hoping that in 10 years from now is going to be even. I wouldn't be able to even comprehend it at this point because I just
Hmm.
haven't reiterated it enough.
Yeah. Well, it sounds like you're doing well and you're excited to grow, and it's awesome to see. And thank you for everything that you've kind of just highlighted. I do want to ask you, it's an honor, first of all, to hear that you said you listened to our podcast, Dr. Una, reading her book, and that it changed the course of your life and how you wanted to practice. What was it exactly that made you take the leap? Was it the ability to lose the fear? Was it seeking, the opportunity? Was it the understanding of the life you're living? And what was it that you could hone in on that made you take the leap?
Yeah, honestly, support of a partner. So my fiance, we've been living together for a few years, and she moved in, and we were having a child. I have a 1-year-old now, but this was basically a year ago. And I just was like kind of fed up with the practice I was in, and wanted to make the jump, and had the conversation with her, and she was like, you should do it. And she even cut me the check to start the practice as like a show of good faith of like, I'm all in with this. And I like truly couldn't be here without her. And she's a nurse, she's from the medical field, she gets it. But yeah, that was really it. I knew I wanted to do it, but there's always, it sounds like you have a new family, and I know, Roger, you have kids. Like you have so much responsibility as a father, as a husband, as a partner, and you want to provide for your family. So that was like very, very scary. But like once you get your partner's blessing on it, and that really changed the corner for me, and that kind of took all the fear away. Just knowing that like if I fail, it'll be okay, and I was okay. I went into this totally thinking that like I could fail, and I still could fail, and that's okay. But at least I know I gave it my effort, and having that support from her, and then from the rest of my family. My mom is now my office manager. This has been it takes a village. Like this, I know I'm saying a lot of stuff that I've done, but like I didn't get here alone. And my dad hung the sign the other day. So like this is like it's a full village effort.
I don't think you will, man. I think you're too determined. You're obviously a brilliant person. And, I can't thank you enough. I mean, like I said, 3 years ago, we met. Initially, you were my doctor, taking care of my hip. And now
I
you're
wasn't
kind
gonna
of
say that hip, but
that's all right. I said it. And, and now you've been very much a role model to me and a mentor. So I want to appreciate you. This has been long overdue. I'm super excited. I hope the people took away some interesting tidbits, and we were able to shed some light on the inner workings and the complexities of the insurance-based model, or just healthcare, that don't need to be as complex. I also want to apologize because after the millions of listeners that we have listen to this, you're going to need more chairs in your waiting room.
okay.
You should get
I'm
ready for
I'm
that.
I'm okay. I'm okay with that problem. And yeah, and the offer really stands. Like I'm happy to answer any question. I am an open book. Like even if patients, you want to run something by me, even if it's not my service, I'm happy to help. So
Yeah. How can people get in touch with me, right? You mentioned your website, socials, give us all that stuff.
yeah, so the practice is Apex Sports Medicine. It's APX. Basically, I couldn't get APEX website. So apexsportsmedicine.com. I'm on Instagram at apexsportsmedicine.com. And then my stuff is available. My office number, my email, everything's transparent. It's the underlying thing of this transparency. So you can find me easily and ask me any question you want. And hopefully you just go on my schedule and you book an appointment, and we get to have 45 minutes to an hour to connect and make some changes and help you out or get you out of pain, whatever is needed.
Awesome. Vince, thank you again, man. Again, I was silent the whole time because I was just soaking in and learning so much. So this is going to be an episode even for me to go through again and just get that refresher on insurance. And that way I can explain it to my patients too. Because I mean, being in rehab, it's 4 days in, we get to find out how many their length of stay, for example. And so it's always a headache and always a constant discussion. So thanks for everything that you brought on here.
I love it. Yeah, and I've been thinking about this. Um, I would say removing the insurance-sized barrier between patients and providers and getting back to accessible, affordable, personalized care. I think the way you do that is to go see either a direct pay primary care provider or direct pay specialty care provider, and make an investment in your health and see the difference in the care that you get.
Amazing. Thanks, Vince.
Yeah. Appreciate it, guys. You guys are the best. Hopefully, in a couple years, I'm back on here. We're talking about something else. So
Amazing. Yep. All right, man.
Oh, I will be. Yeah, we talked before this. I definitely want to play some more golf in Florida. So we'll make that happen.
All right. See you guys.
See ya. Have a